Welcome to another episode of Live Healthy Longer. This is Dr. Jim Polakof. And in today's episode, we're going to be focusing on what we need to know about heart disease. Now, you might be aware, but if not, you should be, that heart disease is the leading cause of death for women and men in the United States. One person dies every 33 seconds in the United States from cardiovascular disease. Well, fortunately, we have a leading cardiologist from Duke to shed light on this scary topic. But first, a few surprising facts about heart disease. If you're concerned about getting a flu shot, listen to this. Studies show a yearly flu shot can actually benefit your heart. Many heart attacks occur on Monday mornings. But Mondays or not, it's believed blood is thicker in the morning, and your body has to work harder to pump blood. What about an aspirin a day? Chewing an aspirin as soon as a heart attack symptoms appear can limit damage to your heart. But this is just the tip of the iceberg regarding what you need to know about heart disease. So let's turn to our expert, Dr. James Wisler, a top cardiologist at Duke Health. Dr. Wisler completed the fellowship in cardiovascular disease and is an assistant professor of medicine at Duke University. He mainly practices in Raleigh, North Carolina. And for you Buckeye fans, this top doc originally graduated from Ohio State's School of Medicine. But if you don't think he's got his hands full treating heart disease, Dr. Wisler is married and the father of 5 children. Now that's a handful. So welcome, Dr. Wisler, to Live Healthy Longer.
Thanks for having me. Excited to be here.
Well, we're excited to have you. Let's begin by letting my listeners know, what is heart disease and why is it the leading cause of death among adults in the U.S.?
So I think it's a great question. I think the best way to describe it is that there are a variety of different types of heart disease. The analogy I often give my patients is that the heart is like any other mechanical pump. It'll squeeze and relax to both accept blood and then eject blood. And in order to do so, it has both a power supply, an electrical supply, and also a fuel supply. So there are blood vessels that supply the heart muscle with fuel so that it can work. Heart disease encompasses the wide spectrum. So heart disease implies you can have dysfunction in any of those functions or all of them. And they can be related or separate, meaning you can have a problem in the fuel supply that causes a problem in the pump, or a problem in the electrical supply that causes a problem in the pump. And that's how I generally describe the spectrum of heart disease to patients.
Sounds like a real mechanical problem.
It can be, for sure. Yeah, that's exactly right.
Related to plumbing in a sense, but we can get into that a little later.
My patients who are engineers seem to get that analogy quite well.
In any case, something a little concerning. I'm told that about 1 in 5 heart attacks are silent, meaning the victim didn't even know that she or he had a heart problem. This is kind of scary.
Yeah, so it's a really good point and a really interesting part of cardiology. So when people classically have heart attacks, what we're talking about is a disruption in the fuel supply to the heart muscle through an obstruction of some sort. Often it's a clot that forms in the blood vessel, but it can be from other reasons. And classically, the description that people give, or the classic clinical syndrome, is chest pain, substernal, usually right in the middle of their chest, that is worse with activity and improved with rest or nitroglycerin. That's sort of a classic description of ischemic chest pain or heart attacks. But that we've observed this phenomena throughout the years, known as what we call silent myocardial injury or myocardial ischemia, which implies that someone had damage to the heart muscle that did not present with symptoms. That can be picked up subsequently down the road through other testing, EKGs, echocardiography, or even sometimes incidentally when someone is presenting for something else. There are some blood tests that we do that can detect myocardial injury, heart muscle cell injury at very sensitive levels. And even then, people may present with something else.
It can come right out of the blue, right? Without any real, I mean, and what's amazing is, obviously, we're going to be talking more about older adults, but I don't think that people are aware of the fact that 2 out of every 10 deaths, coronary artery disease, actually happens younger people, 2 out of 10.
Yeah,
So, I mean, you're at any age, you can be a victim.
it often presents, silent heart attacks can present without premonitory symptoms. The classic patient that we get referred to as someone who's having sort of progressive activity intolerance, shortness of breath, chest pain. But oftentimes we don't get or we don't observe any premonitory symptoms. People present either with a first heart attack or, again, for some other reason. And we say, well, maybe you had a heart problem before. You're exactly right. While the large majority of our patients are older, 50 and over, we certainly see plenty of patients who present at younger ages. And it's one of the key areas of advancement in cardiology these days is how do we identify these people who are at risk at younger ages? Because we know even for those patients, whether it's some genetic predisposition, a familial disposition, some sort of anatomic abnormality that predisposes them, identifying them before they have a problem is key to saving their life in many cases.
Right. Well, we know that it's a huge area to cover if we wanted to cover every aspect of heart disease. So for purposes of this interview, we're primarily going to focus on the main core of, shall we say, heart disease victims, people over the age of 50 or 55 and much, much older. So people often, they've asked me, what's the difference between a heart attack and a stroke? I mean, I think we understand, you and I understand, but for the average individual, is there a significant difference and are the symptoms different?
Yeah, it's a great question. And so the way I would describe these is that there is similar physiology occurring in two different organ systems. So when we talk about a heart attack, kind of what I alluded to earlier, often what we're referring to is a disruption to the blood supply to an area of the heart muscle. Again, classically presenting as acute onset of chest pain or shortness of breath, or even a sudden cardiac death. That's different from a stroke where what happens is an acute disruption to the blood flow to the brain. And often those people will present with speech or swallowing deficits, unilateral numbness, weakness, or motor deficits, and symptoms like that. So it's similar in physiology in that we're seeing a disruption to the blood supply, which just has to do with two organ systems. The actual pathophysiology is generally different, meaning the reasons most people present with strokes are not the same reasons people present with heart attacks, where in heart attacks, it's often a plaque that's within the vessel wall that gets disrupted in a clot form in that area. More commonly for people presenting with strokes, it's a dislodged plaque from somewhere else, like the carotid artery, embolic strokes that are clots that form elsewhere in the body and travel to the brain, things like that.
In essence, their symptoms are somewhat similar, though, aren't they? I mean, pain in let's say your left arm, for example, could be either an onset of a stroke or a heart attack. Is there any real differentiation that says, I think I'm having a stroke? I think I'm having an MI or a heart attack?
Yeah, so for strokes, generally pain is not a more common presentation. Normally, or more commonly, it would be things like unilateral numbness or weakness, a facial droop, more neurologic presenting symptoms, speech or swallowing deficits, fixed gaze with one of the eyes or the other, difficulty smiling, those kinds of things. So
slurring your speech.
Exactly. So I think the things we tell people to look out for are facial droops, not able to smile, slurred speech, focal numbness or weakness. Whereas heart attacks, again, are more commonly to present with chest pain, shortness of breath, sometimes sudden cardiac death where people will, lose consciousness abruptly, those kinds of things.
I guess basically at any age, no one's immune from heart disease, but perhaps we can talk about, particularly for those 50, 55 and older, what are the leading risk factors for heart disease in that age group?
And this is a really good question because I think it really does get it to one of the areas that is advancing quite rapidly in cardiology. Classically, risk factors would be things like age, male sex. So it seems to be a predominance of coronary disease in males versus females. High blood pressure is an important risk factor. Cholesterol, sometimes obesity, tobacco use, smoking in particular, diabetes, are all important sort of traditional risk factors. Recently, there was a paper published in the New England Journal of Medicine, which is one of the more prominent medical journals, where a group known as the Global Cardiovascular Risk Consortium looked at these top 5 risk factors. Again, weight, blood pressure, cholesterol, tobacco smoke, and presence of diabetes, and sought to ask how much of someone's risk can be attributed to these 5 risk factors. And they looked at the risk for 2 things. 1, cardiovascular disease, so heart attacks and strokes. And 2 is the risk of death. And what they found is that the numbers were similar but not identical for men and women. Roughly 50 to 55% of all cardiovascular disease is attributable to these 5 risk factors. Now, that's a combined risk of those 5 risk factors. And roughly 20 or 22% of all deaths can be directly attributed to those 5 risk factors combined. So those would be some of the traditional risk factors we know of. One that wasn't included in that study, but also seems to be important, is fitness level. So we use a unit of measure that's semi-quantitative called a VO2 max. V is the volume, O2, of oxygen that your heart can deliver to your working muscles at peak exercise. This is not something people are normally getting measured in the clinical setting. It's not a very useful thing to measure from a day-to-day clinic. It is something we'll measure in a certain subgroup of patients by putting them on a treadmill and using gas exchange. And that's usually patients who are being considered for cardiac transplants. But now within the age of all these wearable devices, many of the wearable devices will calculate a VO2 max, a fitness level, based upon your performance during exercise. So what speed you can maintain for what amount of time and things like that will help calculate a VO2 max. And we know that VO2 max strongly predicts someone's risk of not only dying, but also cardiovascular disease. So it's another important risk factor.
So now we're talking probably about things like, obviously the Apple Watches that are out, things of that nature that actually can, give you a sign that something like that is happening. And I think there are some portable devices as well available.
That's exactly right. So the Apple Watch and other wearable devices are really good about predicting someone's fitness level. Now we have devices that can do portable EKG monitoring. They're not traditional 12-lead EKGs, but the Apple Watch is an example that gives us some EKG monitoring. So I often will have patients send me those, which is helpful. KardioMobile makes a device called the AliveCore KardioMobile device that can do a 6-lead EKG, which is very helpful. They're not 100%, but they're very, very close, and they help us do a lot of monitoring for people with primarily rhythm disorders. They're not as helpful for saying heart attack or no heart attack, but certainly they're helpful for people with abnormal heart rhythms.
Well, I have 2 quick questions. One I'm going to get back to in a second, but you mentioned men and your statistics. I've read that older women seem lately to have a higher degree of risk in terms of heart disease. Is there any validity to that?
I think that probably depends on the heart disease you're talking about. There are certainly some heart diseases that tend to be more common in women than men. In general, though, coronary artery disease tends to be about a 3 to 4-fold more common in men as we get older. So the risk of dying from heart attacks is higher in men. The risk of developing coronary artery disease and heart attacks tends to be higher in men. We think that it's attributable to all the things that make men throughout their lives, whether it's testosterone directly or all the things that come along with those hormonal differences. But the risk tends to be higher in men. So one of the things I like to do for patients when we're talking about risk in our clinic is I can show them right in front of them, if we put all their risk factors in, again, age, smoking history, diabetes, blood pressure in the clinic that day, their most recent cholesterol numbers, we can put those into a calculator and with reasonable accuracy predict their risk of having an event in the next 10 years. And one of the things
that's interesting.
And I like to show patients what the difference would be if they were a male or female, meaning I like to show them there are some risk factors we can do something about. There are some we can't do anything about: age, sex, those kinds of things are what we call non-modifiable risk factors. So, I might show a 77-year-old gentleman, his risk of having an event in the next 10 years is 18% based on traditional risk factors. And then if he were a woman with the same exact profile, his risk might be closer to 9% or 7%.
Mm-hmm.
And so I think those are useful for patients to see how we think about risk. Now, these calculators.
And by the way, if you are seeing a cardiologist, because my podcast goes throughout the country, if your cardiologist or even your primary care physician is not suggesting this type of an evaluation as a patient, you can request it, correct?
Oh, yeah. And it's super easy to calculate. I mean, it takes about a minute because it uses, I think if I remember all of them, it's age, sex, tobacco history, presence of diabetes, blood pressure numbers, cholesterol numbers.
Right. What about heredity? Is that a risk factor?
Yeah, so it definitely is. And some risk factors will incorporate a family history of a heart attack. The one that was developed by the American College of Cardiology does not. So there's no family history incorporation. You can imagine that becomes a very challenging risk factor to quantify. And so we have some other tools that we'll sometimes employ to help us try to assess someone's risk. But as you point out, this is a very simple question to ask both primary care or cardiology if you see one, with the benefit that depending on what that risk is, we can make recommendations for prevention medicines or not, things like aspirin or statin or better blood pressure control. Those questions or those medicines are often recommended in the context of someone's overall risk. And those calculators are very helpful to calculate that.
So, Dr. Wisler, let's get into the prevention of heart disease. As the saying goes, you are what you eat. So, what do you consider comprises a healthier diet to prevent heart disease, or if necessary, live healthy with it?
So this is an interesting question because it's one that I would say is understudied in the field of cardiology. That's for a variety of reasons, and some cynical, some less cynical. But I think the diet that appears to be winning currently is a diet that's high in omega-3 fatty acids. So this would be something like the Mediterranean diet, fish, olive oils, tree nuts, something that tends to have a lot of fiber, and low in simple sugars, we call that a glycemic index. So foods that have a low glycemic index, and a good amount of fruits and vegetables. We used to recommend these diets that were low in saturated fat, and those diets turn out to not really have much of an effect on someone's risk. So I think right now, the diet that would probably be the one that most are recommending is the Mediterranean diet or something along those lines.
Yes, and that's why I've always favored the Mediterranean diet.
Yeah, it's a little bit complicated. They've tried to investigate this question in clinical trials and appear to the largest clinical trial that was published on this appeared to had to be retracted after it was published because of some issues with the data quality. So we don't really have the largest clinical trials telling us that that's the right diet, but certainly I think that's what the smaller trials would tell us, is that's probably the right diet.
We know exercise is important in either preventing or dealing with heart disease. So, Dr. Wisler, in your opinion, what is considered to be too little or what would be too much exercise?
So this is another area that doesn't get as much study as some of the pharmaceutical agents, but I think is more important. So the answer to the question is that any exercise is better than no exercise. And that's exercise that gets your heart rate elevated. That is better than no exercise for a variety of reasons. One of which is the benefit it confers on your cardiovascular risk. The total number of how much to do right now, the recommendations are 150 minutes a week of moderate intensity exercise. There's a lot of evidence that suggests that we might be able to get away with different types of exercise for shorter periods. So exercise known as high intensity interval training, which is very intense, but short bursts of exercise, getting your heart rate to 75 or 85% of your maximum predicted heart rate for a minute or two at a time, let it come back down and then back up, also seems to be exceptionally beneficial for a reduction in your risk. There is some data that might suggest that there could be a limit to how much exercise is beneficial. So there's some data that suggests perhaps marathon runners, for instance, who perform hours and hours a week of moderate intensity exercise may have an increased risk of some cardiovascular diseases such as atrial fibrillation or abnormal heart rhythms. We think there probably isn't a limit to the amount of exercise that's healthy, just that the benefits of exercise start to reach an asymptote or diminishing returns as you get up above 150 or 300 minutes a week of moderate intensity activity.
The key is not to take a casual walk, but to get your heart rate going, correct?
Yeah. So oftentimes what I'll recommend to my patients is finding a hill on their walk that they can go up and down a few times, because I think that's a good way to get your heart rate up and keep it up for a sustained period. If you go back down, do it again, even better. Or I'll even talk about walking upstairs or something like that to elevate the heart rate a little more than a casual walk.
When a patient says, I keep having these weird sensations in my chest, my primary care doctor says, well, it might be atrial fibrillation. So, Dr. Wisler, what is atrial fibrillation, and how do you go about determining whether or not a patient has AFib?
Yeah, so atrial fibrillation is, as we talked about earlier in my analogy of problems that can go on in the heart, would be an electrical problem. And what it implies is that you have cells within the atrium that are firing abnormal or irregular electrical impulse signals, such that the electrical impulse is getting conducted to and through the ventricles at irregular intervals and fast speeds, potentially fast speeds. So oftentimes people that develop atrial fibrillation will present with either an abnormal rhythm where it's irregular, or a fast rhythm, or both. The way to diagnose it, so the first thing to know about atrial fibrillation, it's the most common arrhythmia in the Western world. Roughly 25% of people over the age of 65 will get atrial fibrillation. So it's millions of people. It's a very, very common arrhythmia. It can present with multiple clinical phenotypes. So the most common is what we call paroxysmal atrial fibrillation, where you'll have episodes of this funny rhythm, and they'll come and go whenever they want. Sometimes it's once a day, sometimes it's once an hour, sometimes it comes and stays for a few weeks, sometimes it's once a decade. It depends very much on the patient. And there are different things that might predispose someone to more or less paroxysms of atrial fibrillation. Often people will present with feeling some funny beats in their chest. The way that we can definitively diagnose that is either in the office setting, if it's observed on an EKG. At the home setting, we have monitors, generally referred to as Holter monitors or mobile cardiac telemetry devices that people can wear for up to a month at a time that can identify it. So for instance, if you're having an episode once a week, you might wear a monitor for 2 weeks or a month. And when you have an episode, you'll press the button on the monitor and the monitor will record it and say, okay, this is what was going on when you were symptomatic. Often these monitors are programmed to recognize atrial fibrillation on their own. So if the monitor observes it, it'll save that recording anyway. So if you have it when you're sleeping, as an example, it'll record it and say, oh yeah, and many of the monitors will even quantify how much atrial fibrillation you have. So they'll say you had it for 3 hours and 44 minutes, the total percent was X. So that's often the way it's diagnosed. In this day and age, as we mentioned earlier, now people have these wearable devices. So even some of the watch monitors are very good at detecting atrial fibrillation with a high sensitivity, meaning if you have atrial fibrillation, they're very likely to pick it up. The specificity is not as high. So they'll call some things atrial fibrillation that are not atrial fibrillation. But because the sensitivity is high, that's kind of what you want for a screening tool, meaning it's not going to miss it or very unlikely to miss it if you have atrial fibrillation.
Well, let's get into how you treat it. Obviously medication, but also there are some surgical procedures, correct?
Yeah. So the way I describe the treatment for atrial fibrillation to my patients is that there are two separate but interrelated goals. Probably the more important goal for people with atrial fibrillation is that depending on your risk factors, your risk for stroke may be increased with this condition, and that we talk about ways to reduce that risk. And the way to reduce that risk, depending on your risk factors, is with medicines known as oral anticoagulants. These are medicines that reduce someone's risk to have a stroke by thinning the blood so it doesn't form clots as well, which that's one of the probably the most feared complication of atrial fibrillation. The second treatment goal for people with atrial fibrillation is to reduce their symptomatic burden. And we do that through one of two strategies. So one strategy is what we call rate control, where we just try to limit how fast your heart rate goes when you go into atrial fibrillation. So we use medicines like beta blockers or calcium channel blockers to just keep your heart rate from going too fast when you go in atrial fibrillation. The second strategy is what's called rhythm control. So this is where we use either medicines known as antiarrhythmic drugs or procedures known as ablations to keep people out of atrial fibrillation. And for oftentimes those people are the people who are very symptomatic when they go in atrial fibrillation. And the ablation procedure is a relatively new procedure. In the last, say, 20 years, it's been developed, and it continues to evolve such that 10 years ago, it may not have been the first line therapy. Oftentimes now we're recommending it more upfront because we think it really does reduce someone's risk long-term to continue to have atrial fibrillation episodes. And so as the technology and the techniques and the utensils they use continue to evolve, I think you'll see that become more and more common for people up front.
Like any car that ages, it may need parts to be replaced. And of course, the same thing happens to our body when we get older. So let's discuss aortic valve replacement. First of all, what is an aortic valve? Why is it important? And is this going to mean open heart surgery?
Yeah, it's a great question. So the heart is, again, a mechanical pump. It has 4 chambers, 2 on the top that are small, sort of weakly muscular chambers known as atria, right and left, and 2 bigger chambers on the bottom that are thick and muscular known as ventricles. The musculature of those has to do with the genetics of each of those chambers, but also what they do. The right ventricle squeezes blood to the lungs, the left ventricle out to the body. So they have to be strong enough to eject that blood, generate a change in pressure to move blood forward. For people that have problems with the aortic valve sits between the left ventricle and the aorta, which is the main blood vessel that comes out of the heart and supplies the rest of the body. That aortic valve, when the heart squeezes, when the left ventricle squeezes, the aortic valve opens up and allows blood to move forward. Then as the left ventricle begins to relax, pressure drops within the left ventricle, and that pulls the aortic valve closed because of the pressure change. What can happen for people with aortic valve disease is you can have either stiffening or narrowing of that valve or leaking of that valve or both. And there are certain genetic conditions which predispose people to aortic valve disease, but it is one of these diseases that becomes very common as people get older. Your analogy is perfect, which is that the parts of your body are kind of like the parts of your car, and the more miles you put on them, the more likely they are to have some damage. And that we often see that with the aortic valve. Traditionally, the fix for a narrowed aortic valve, a stenosed aortic valve, was open heart surgery, where they'd go in, take out the valve, put in a new one, either a mechanical prosthetic or a bioprosthetic.
A serious surgery.
Yeah, it is a very serious surgery. Thankfully, the techniques are excellent and the risk of that surgery is quite low. But there was a large group of patients who were too sick for that surgery. They could not tolerate open heart surgery. And so what's been developed in the last 20 or so years are these devices that are, or valves that are delivered through a transcatheter approach. This is called a TAVR, or transcatheter aortic valve replacement, or TAVR, and they're becoming much, much more common. What they are is a way that we can use minimally invasive techniques going in through a artery in the leg, an artery in the neck, even sometimes through the heart itself, to deliver these valves, where we put them in place on a balloon and then inflate the balloon to inflate the new valve inside the old one. And so these were originally developed for people that were too sick to undergo surgery. But then, thankfully, they proved that in those people, they could help save lives and that people could tolerate this and that these valves were durable. So they started to increase the groups with whom they're trying these. So in people who are at high risk but still could go surgery, or people at moderate risk or low risk for surgery, those are now the people for whom we're starting to do these procedures. And you can imagine the recovery from transcatheter approach, where they don't open your chest and you don't have all that, is quite good. And the techniques and technology, the devices, the valves themselves are becoming so advanced. It's really, that area of the field has moved tremendously, even in my own career over the last 15 years.
What you replace your aortic valve with, it can be a foreign material. Am I correct? It could be a plastic type of device, or something to do with the cattle or a cow device.
So it's a great question. So when we do the surgical aortic valves, there's usually 2 options. One is a fully mechanical valve, and the other is what's called a bioprosthetic valve, where the valve has the leaflets of the valve are made out of material, either bovine material from a cow or porcine material from a pig. The benefits of those and the risks are things we debate with the patient or discuss with the patients before we do them. Very sort of briefly, the mechanical valves tend to be more durable. So we might consider using those in younger patients. If you have to get your valve replaced at 45 years old, and then we don't want you to have to go through another heart surgery later, we might say the mechanical valve is the right valve. The problem or the complication with the mechanical valves is that because it's a mechanical device, your risk for forming a blood clot on those valves is higher. And so those patients will go on blood thinners the rest of their life while they have that mechanical valve inside of them. The bioprosthetic valves, on the other hand, don't require any anticoagulation, but we don't think the durability is as long. So they might not last 30 or 40 years. And so for those people, generally for older folks, if someone's 80 years old and they need a valve replacement, the traditional approach may have been a bioprosthetic valve because we think the valve will last longer than they will. The odds would be to pass away before the valve deteriorates. In the era of transcatheter valve replacement, so the transcatheter valves are all bioprosthetic, but we've now been doing these procedures where if someone gets a valve replacement with a bioprosthetic valve and that valve starts to deteriorate, there starts to be dysfunction, it needs to be replaced. Sometimes we'll even go put a transcatheter valve inside of the old valve. So what we call a valve-in-valve procedure. And that's been shown for a good number of patients to be useful. So we can talk about maybe you'll get 2 bioprosthetic valves, over the course of your life, and that'll be okay. And the second one's going to be a transcatheter approach. So that's a more novel technique to say maybe we don't have to do the mechanical valves in some people who we might have otherwise done them in.
So, Dr. Wisler, let's talk about a concern which typically has involved major surgery. It has to do with clogged arteries, and I've seen pictures of clogged arteries, particularly people who have been on red meat diets most of their life. Is bypass surgery for clogged arteries a thing of the past? And can stents now do the job? What's your take on this?
So when people develop coronary atherosclerosis, coronary artery disease, they develop these lipid-laden plaques within the walls of their arteries. Those plaques tend to grow both by the deposition of more lipids, but also through an immune response that's mediated against those lipids in the plaques. Those plaques can then narrow the vessel, the lumen of the vessel, the inside of the vessel, such that your body can't deliver adequate blood flow through those narrowings. In those scenarios, people will oftentimes develop chest pain, heart dysfunction, so the heart muscle that's affected may not pump as well. And oftentimes we'll recommend revascularization, where we open up the vessels. There's 2 ways that we do that primarily. One, as you mentioned, is bypass surgery, and the other is through stent placement. This is done, again, through a catheter-based approach. Often the decision to pursue one over the other is made by the anatomy. So where the blockage or the narrowing is, how many blood vessels are involved. We think that the more severe, the more vessels that are involved, the more likely they are to benefit from bypass surgery over stent placement. The coronary arteries are designed kind of like the back of a leaf, where you have a major artery with branches and then smaller branches and even smaller branches off of each of those main stems or leaves. And the interventions are most helpful for those that are in the larger arteries. One such artery is the left main coronary artery. The left main coronary artery is one of 2 major coronary arteries, the other being the right coronary artery. The left main, immediately after it takes off of the aorta, splits into 2 arteries, the left anterior descending artery and the left circumflex artery. The left anterior descending artery moves down the front of the heart and supplies about 2/3 of the overall heart muscle. So it becomes a very important blood vessel for people to maintain adequate flow through. This is commonly referred to as the widowmaker, because this is the one where if people have heart attacks in it, they often don't survive. For people who have blockages, narrowings near the beginning of that left anterior descending artery or involving the left main coronary artery, those people seem to benefit from bypass surgery over intervention, over stent placement. Bypass surgery involves taking the artery often off the chest wall, called the anterior mammary artery, so on the left side, or vein grafts, or even other artery grafts, such as the radial arteries, and suturing them into or beyond the narrowing, the blockage. There's been some really novel technique changes in the last several decades to try to minimize the overall burden of that surgery. It's a very effective surgery, but again, it involves a sternotomy where they go through the middle of the chest. There are many surgeons now who are trying to do this minimally invasive, where they either can go between the ribs or do it as a hybrid procedure where maybe they do a bypass around the left anterior descending artery, but then put stents in the other arteries. And this is a very hot area of research in cardiology, because we want to know, how can we treat people the best? Are the stents effective,
Right.
or are they ineffective relative to bypass?
So let's get back to risk factors. How can you conclusively determine if a patient is at risk for a heart attack or a stroke? Is it a treadmill test that you use, or an echo, or both? What's the difference in these tests, and are there others that should be considered as well?
Yeah, I think some of this has to do with, some of this should be thought of as a probability argument or a probability discussion, which is that we can make some statements about what a patient's overall risk is, what their probability of having an event is, say, in a 10-year window. And then we have other tools that help us say, okay, beyond their traditional risk factors, what might their risk be? One of the key differentiating factors is symptoms. So a stress test is very useful in someone who's having concerning symptoms, chest pain, shortness of breath, things like that, at saying, can we attribute those symptoms to a blood flow blockage to the heart or not? So we put people on treadmills. Sometimes we'll do this with medicines to simulate stress. We can monitor an EKG, which will have some characteristic changes if there's a blood flow problem, or we can add imaging modalities, whether it's a CT scan, nuclear camera, echocardiogram, MRI, that'll look directly at the blood flow or indirectly at the blood flow to the heart muscle to say, oh, yeah, when he got to peak exercise on the treadmill, there's evidence on this study that there's a blood flow problem. Those are most helpful in symptomatic patients. Other tests have been identified and or developed to try to help us gauge someone's risk. So this is looking at a more in-depth lipoprotein file. So we use something called nuclear magnetic resonance, or NMR, to really break down not only the broad categories of lipids, but also how many of the particles there are, what their sizes are. Those tend to be associated with different levels of risk. We can look at other lipoproteins besides the standard LDL, HDL, triglycerides. So we look at something called apolipoprotein B, LP little a, or lipoprotein little a, as independent risk factors for coronary disease. Another test that maybe many of your listeners have heard of or even undergone is coronary calcium score. And what they're looking for is to say, okay, based on your traditional risk factors, this person's risk might be X. And the calcium score is really useful for saying, if your calcium score is elevated and it's age and gender based, if it's elevated above what we might expect, it might say, yeah, instead of the risk being 10%, it's actually 14% or 20% based upon that calcium score. So they're very helpful tests for risk stratification. They're not as helpful for saying any of the atherosclerosis is limiting flow. So that's where the stress test comes into play. So this is something we go back and forth with for patients who have undergone some of these life screens or other things about what does it actually mean to have an elevated calcium score.
Well, Dr. Wisler, we're at the point of this interview where time has crept up on us. I'd like to conclude by asking about the world's first miracle drug, aspirin. When you reach a certain age, does taking a daily dose of aspirin, let's say 81 milligrams, really help to prevent a heart attack or a stroke?
So this is a question that surprisingly has been debated back and forth for many, many years in cardiology. You think this would be a question that we'd have a straightforward answer to, given aspirin's been around forever. And we do have some better answers than we used to. What I would say is that the decision to use aspirin as a preventative strategy should be based on an individual patient's risk. There are many different ways in which we can sort of quantify someone's risk. And that aspirin in general is associated with a roughly 20 to 25-ish% relative risk reduction. So what does that mean? What does a relative risk reduction mean? Well, it says if your risk of having an event in the next 10 years is 2%. Then if we lower that by 25% from a relative perspective, we can lower that to 1.5%. That's a 25% relative risk reduction, but we only really change your risk of having a problem from 2% to 1.5%. So you can imagine if that comes at the cost of a roughly 2 or 3% risk of bleeding, either requiring transfusion or hospitalization, you might say the risks of that intervention outweigh the benefits.
Right.
But if your risk of having an event is 25% and we lower it to 20, well, that might be worth it in terms of a risk reduction. So aspirin sort of falls into this area where its benefits are most beneficial in people who are at the highest risk. So who's that? Well, people with established coronary disease. So people that have known coronary disease, people with diabetes, many of them will be at a very, very high risk. People with multiple risk factors, so family members, a really elevated coronary calcium score, high lipids, those kinds of things would also be people who I think would benefit from an aspirin. People for whom it wouldn't be particularly beneficial, young people who are at low risk, so no family history, otherwise healthy young people, people with a history of significant gastrointestinal bleeding, so bleeding from their GI tract, otherwise healthy adults, even people over the age of 50 or 60. It's probably not the right medicine. There was the United States Preventative Services Task Force is a organization who helps make recommendations about prevention therapies. And recently they changed their recommendation on aspirin use in otherwise healthy adults above the age of 65 and said the risks probably outweigh the benefits, which I think is a pretty reasonable assessment of the data.
Interesting. So again, a lot of this is going to depend upon getting the right kind of information. There are people who don't see their physician, their primary care doctor, or their cardiologist very often, and they just cruise through life on their own. Obviously, that's another good reason why you need to see your primary care doctor regularly. And if there's any possibility of heart disease, get to know your cardiologist.
Yeah, I think that most primary care physicians feel very comfortable with these risk assessment tools and feel very, are well equipped to at least have the initial discussion about what to do and to refer you to cardiology or not. But I think that's the right thing. I mean, it is the number one killer of adults in America, and there's a reason why. It becomes very common as people age.
Well, Dr. Wisler, you've been very informative, very articulate, which I want to compliment you on. You've taken on technical terminology and you've been able to put it in lay terms. So I think most of, if not all of our listeners can really understand what you've been talking about. I mean, such important information you've given us, perhaps even helping to save some lives down the line. But I want to really compliment you, for your articulation and thank you on behalf of myself and our audience for being with us.
Well, thanks for having me. Like I said, I appreciate it and look forward to seeing you soon.
All right. So anyway, I'll be right back with a message about heart-healthy nutritional tips.
Be sure to visit our website, jamespolakof.com, to learn how you can reach Dr. James Wisler at Duke. You'll also find other great podcasts and terrific blogs. That's jamespolakof.com. James, Polakof.com. Now back to Dr. Jim.
As a nutritionist, I'm a big fan of the Mediterranean diet, particularly for heart disease prevention. It focuses upon vegetables, fruits, whole grains, and plant-based fats. Plus, don't forget about replacing meat with fish. It can be very beneficial. Salmon is a good example. Now, I'm often asked about what specific foods can actually boost heart health. Well, here they are. Berries, dark chocolate. Yum, that's right, dark chocolate. Potatoes, particularly sweet potatoes or yams. Legumes, tomatoes, nuts, olive oil, and coffee. That's right, starting your day with a cup of coffee is a plus for your heart. So be sure to tune in each week for a new episode of Live Healthy Longer. And again, as a reminder, we've got some great podcasts and healthy blogs on our website, jamespolakof.com. Thanks for joining me. And be sure to have a heart-healthy week.